Hello, I'm Richard Oehler, Associate Professor of Medicine with the Division of Infectious Diseases at the USF College of Medicine. And it's my pleasure to present this podcast to you, sponsored by IDPodcasts.net and USF Health. The focus of this lecture is to convey how we can make ourselves better infectious diseases specialists and clinicians by using all the resources we have at our disposal. For almost 40 years now, one of those essential resources has been the Sanford Guide. For many of you listening to this podcast, it's likely in your jacket pocket right now. Knowing all the ways the Sanford Guide can help you, not just as a quick reference, but also as a chronicle of the changes that occur to therapeutics over time, can be an invaluable aid to your practice. The origins of the Sanford Guide date back to the late 1960s. There were few pocket references then, other than perhaps the Merck manual. This was an age of slide rules rather than calculators, where the term EMR was perhaps confused with a baseball statistic rather than a medical record, and where the average computer filled up a large-sized room. In this time, author J. Sanford was a distinguished clinician and educator. Back in about 1967, while at Southwestern University in Dallas, he gave a grand rounds talk on the semi-synthetic penicillins and put together a handout to give out during his talk. This outline was the very first iteration of Table 1 in the guide. Jay gave this out to house staff and kept a copy in his pocket during rounds. Around 1967, his department got a new Xerox machine, and he reduced his outline to 4 by 6 inches to make it convenient. His wife bound it in cardboard as the first guide. The first published edition was produced in 1969 at a local printer. Yearly updates followed, for the most part except for 1973. In 1975, a pharmaceutical company ordered 5,000 copies, and other large orders followed. The readership of the Little Green Manual, as it was called, took off when it became a popular promotional item by the pharmaceutical industry. Colored covers were introduced in 1980. Dr. Sanford was the sole editor until the early 1990s. Other authors also contributed to the publication over the years, including Merle Sandy and Julie Gerberding. When J. Sanford passed away in 1996, other contributors continued their involvement with the guide. Over the years, the guide has been a bellwether of many historic events in infectious diseases, including drug-resistant malaria, Legionnaire's disease, AIDS, MRSA, bioterrorism, SARS, avian influenza, and most recently gram-negative rod superpathogens. Literally a cornucopia of the history of infectious disease reflected in its pages over some 4 decades. The first editions were hand-typed, and you can see in this reproduction of the first page that infectious diseases has changed quite a bit since the first Table 1 was created. This was the age of the importance of penicillinase-resistant antistaphylococcal penicillins, and drugs like chloramphenicol and gentamicin and streptomycin were all we had. The cephalosporins weren't yet a major force on the map, and ciprofloxacin also was a drug really yet to become released and in widespread use. A comparison of the first and 40th editions exemplifies how much the Sanford Guide has changed over the years. The 1969 version had 1 author and 28 total pages, and a single pocket edition. The 40th version has a total of 5 authors, including, I've listed 2 here, Gilbert, Mollering, but also Eliopoulos, Chambers, and Sag, plus several contributors, including Andy Pavia, David Freeman, and Doug Black, each lending their expertise in a field of infectious disease medicine. And there are a total of 4 separate editions of the Sanford Guide, from the pocket or most popular edition to the spiral, hardbound, and electronic editions as well. Current co-authors include David Gilbert, a past president of the IDSA, Robert Moellering, who's a leading expert on antimicrobial mechanisms of action and resistance and an authority on infectious disease therapeutics, both nationally and internationally, George Eliopoulos, who is editor-in-chief of Antimicrobial Agents and Chemotherapy, Michael Sag, all of us know as a major authority in HIV medicine and director of the Center for AIDS Research at UAB. He is also an HIV Medicine Association member on the IDSA Board of Directors. And Henry Chambers is professor of medicine at UC San Francisco and chief of infectious diseases at San Francisco General Hospital. Dr. Chambers is also a major authority in the subject of Staphylococcus aureus and other gram-positive infections. Now, for those of you in the audience who are not as familiar with this pocket publication, why would you want to use the Sanford Guide? Well, it is one of the easiest ways to access key ID information, particularly if you know where to look. Its most popular edition is in a pocket format and is designed for quick access to key therapeutic info on the go. The information is updated at least yearly in the print editions and more frequently in the electronic editions. And the reference material is extensively referenced and cited and provides citations in the literature to provide a scientific basis for clinical decisions. The Sanford Guide is widely available in most medical bookstores. It's also available through educational partners, both in the pharmaceutical industry and in other industries, and this makes it very accessible to most clinicians. Emerging, and something I'll talk about at the conclusion of this presentation, is the electronic web and smartphone editions. However, the pocket printed version is still the most popular format, and I'll base my presentation on this form of the guide. Now, sometimes as an infectious disease clinician, I feel like I get sideways glances from other non-ID physicians whenever I look up something in the Sanford Guide in front of them, as if they are saying, "You're an ID doc, shouldn't you know this stuff already?" Well, that's an interesting point. Let's say that I wasn't a doctor, but instead I was a chef. How would you feel about my kitchen skills if I never consulted a cookbook? Or if I were a chemist and I completely ignored the periodic table of the elements? The way I see our use of reference material, infectious disease clinicians have the background and the training to appreciate the subtleties of treating an infection with one agent or another. We also understand that therapeutics change constantly. Last year's malaria treatment, for instance mefloquine, let's say, may be superseded by this year's artemisinin, and the Sanford Guide usually acknowledges these changes earlier than anyone else. So how do we interface with the wealth of information contained within the guide? Most people start with a flip open of the guide to page 1. The authors have placed a quick reference guide on the left-hand side and a full table of contents on the other. Now let's say you want to examine the antimicrobial spectra of antifungals. Well, if you look on the table of contents and scan downward under antimicrobials on the left-hand side, you'll see that antifungal spectra as well as dosages and side effects are represented on characteristic pages. You can also look at the right side of the guide under table 11A and see that treatment of fungal infections is given its own section on page 98. So through the use of these quick page guides and table of contents to the Sanford Guide, it's quite easy to flip to the section containing the reference material that you want to interact with. Now, everyone who uses the Sanford Guide has their own favorite sections, and in the case of the printed guide, perhaps heavily dog-eared pages. But I like to classify the content contained in the guide in three categories. Number one, what I consider to be the essentials. These are items that consist of mission-critical information vital to your practice that you are likely to refer to often. You may also like is information that is also important, but that you may need to review occasionally, or may want to check every now and then when you may need to refer to something that perhaps you're less familiar with. Just in case you need it, this is reference material that you may rarely need, but when you do, you'll be glad it's in your pocket. So let's look at what I consider to be the essentials. Table 1. This was the first reference source created for the guide by Dr. Sanford in the late 1960s. This is really the heart of the guide and comprises the largest single section in the Sanford Guide, some 58 pages. This section of the guide alphabetically lists the site of infection, as well as giving other information such as the pathogen, primary and secondary choices for therapy, and a comment section that lists other relevant information that may not make its way into the other columns. So this section is, as I said, the largest single section in the guide. And for example, if you want to scan down and look at contiguous osteomyelitis without vascular insufficiency, and they note a foot bone, for example, with osteo due to a nail through the tennis shoe. Of course, they list the common etiology, Pseudomonas aeruginosa, and the suggested regimens for primary and alternative therapy, specifically a anti-pseudomonal quinolone or a drug such as cefepime or ceftazidime. In the last column, they note that there is a separate section regarding a nail puncture, which may also be helpful. And this is a typical format for information presented in table number 1. Let's look at another section, specifically infected endocarditis of the culture negative variety with Q fever. And as well as noting the most likely etiology, Coxiella burnetii, and you also have what is listed, including review articles cited for the diagnosis, the etiologic agent, and the preferred therapy. Now, the contents of the far right column, as I've said before, can vary from alternative therapies to management strategies to diagnostic criteria. But it's usually always relevant to your practice. Antibiotic dosages relevant to the page are usually placed at the bottom for quick reference. This is a trend that I've seen in recent years, and it does divide out that information so it's easily retrievable, usually at the bottom of the page. I also consider Table 2 a must-read reference. If you have a common bacterial isolate and want to know the recommended therapy, it's very easy to find it here. For instance, if you look up Eromonas, you'll find that the preferred agent is a quinolone, but if the patient is fluoroquinolone allergic or experienced, alternative agents are also listed. The table selectively lists which agents are resistant to the pathogen, letting you know which antibiotics you should not use for a specific pathogen. I also consider Table 4 to be an essential reference in that it gives you a quick survey of the antibiotic susceptibilities of important pathogens across several drug classes. It's always important to remember, of course, that your own hospital's pathogens may vary. So take this under consideration, but always refer to your hospital's own antibiogram for comparison. Table 8 includes pregnancy risk category information. And looking this up for a specific antimicrobial is typically done in the PDR or in Hippocrates, for instance, or Micromedics. But what I like about Table 8 is it places all of this information on a single page organized by antimicrobial class. Remember the significance of the classes. Class A, of course, is no risk. Class B is no risk in animals, or human data is not adequate, or there is animal toxicity but human exposure is thought to be of no risk. Class C involves animal toxicity, or human studies are inadequate, but the use of the drug, the benefit that is, may exceed risk. Class D agents have human risk and the benefits may outweigh the harm. Class X are documented as having specific fetal abnormalities. Table 10D makes dosing of aminoglycosides easier both for multiple daily dose and once daily dose regimens. Creatinine clearance formulas are included to facilitate calculations. Note the warnings about aminoglycosides. Remember that aminoglycosides, of course, can cause renal insufficiency at any specific dose. So this information, as a reminder, is helpfully included in bold. Again, this isn't absolutely essential information to prescribing these agents, but this is a good example of how you can learn a lot about therapeutics just by reading the comment sections in the guide. And these comments are updated every year, of course. Antifungal therapy is one example of an area of therapeutics that has become much more complicated in recent years. Perhaps the only other section of the Sanford Guide that has changed so much in recent years is HIV therapeutics. For some of the most challenging mold infections, such as Aspergillus, I think the Sanford Guide does an excellent job of presenting the available antifungal options as well as the different manifestations of the disease. So if you look here under invasive pulmonary or extrapulmonary aspergillosis, you'll see primary therapy outlined, including the use of voriconazole, as well as alternative therapies, particularly the liposomal amphotericin B products, and echinocandin, or an alternative azole. So this is well laid out in the section, along with the comments section highlighting some of the caveats involving the use of several of these antifungal agents. So again, a very informative section that gives you the particulars of the use of these antifungal agents. Now let's look at one listing as an example of all the types of information that the Sanford Guide can give you. In this one section, which only comprises 2 columns, the listing lists the amphotericin B deoxycholate dosing, susceptibility info, the trade name, the dispensing info, the infusion length, side effects, side effect management, toxicity, and drug interactions. That's all listed in this one section. It's really an amazing collection of comprehensive information contained in a single listing of the guide. So again, a wide variety of information available in your pocket in an easy to read format, which will give you essential information for managing an antimicrobial agent which is typically fairly difficult to use and requires some expertise at avoiding significant side effects. And again, I think kudos to the editors of the Sanford Guide for being able to include that much information compressed into a single listing. Now, in my mind, Table 11C is one of the most valuable sections of the Sanford Guide. Antifungal agent microbial spectrum of action is notoriously difficult for many clinicians to recall. If you want to recall what antifungal agents have effective coverage against Fusarium, for example, or whether you can treat Candida krusei with fluconazole, you cannot, of course. You need to bookmark this page. I think it's very helpful for differentiating particularly the different strains of Candida and which ones may be resistant to fluconazole or susceptible to other azoles. Also, some of the lesser known fungi such as Fusarium, Cedosporium, Zygomyces, and allowing the infectious disease practitioner and also the non-infectious disease practitioner to know what agents are useful for the treatment of these somewhat obscure antifungal pathogens. Now, treatment of mycobacterial infections can also be confusing, and Table 12 of the Sanford Guide presents this info in a well-organized way. Table 12A includes a nice summary distinguishing between tuberculin skin testing and IGRA or interferon gamma release assay testing, which is, of course, gained significant prominence in the diagnosis of latent TB in recent years. The treatment of active TB page includes dosing info for adults and kids, dose duration, isolation info, dosing for second-line therapies, and an outline of TB risk factors. A simplified treatment algorithm is included to guide therapy. And this, of course, is based on MMWR tuberculosis guidelines. Side effects of antimycobacterial drugs are extensively covered in Table 12B. The most common side effects are bolded for easy reference. If you are not a regular TB treater, pay attention to the surveillance column, which is an important reminder of what regular monitoring should be in place when patients are on specific TB drugs. Table 13 involves the treatment of parasitic infections, and like others such as the mycobacterial table, it's divided into therapeutic recs and dosage/adverse effects sections. Therapeutic recommendations for the most common parasitic infections, whether they be protozoa, trematodes, cestodes, and ectoparasites, are included. But the table includes the warning that many of the drugs mentioned are not available in the U.S., and obtaining them may require contact with the CDC to obtain these, in some cases, non-licensed therapies. But the table, I think, is a very welcome insight into the role of somewhat less common antiparasitic agents worldwide in the treatment of these very treatment-resistant infections. Table 13B does a nice job of summarizing drug availability, info, dosages, procurement information, and adverse effects of the antiparasitic drugs. Now, for the antiviral therapy sections in Table 14, the viral information tables are roughly divided into non-HIV as well as HIV sections. Table 14A, Antiviral Therapy. This section appears to be especially richly detailed with literature information pertaining to outbreaks. You can see adenovirus, enterovirus, hemorrhagic fever, Ebola, and Marburg represented in this section, as well as hantavirus pulmonary syndrome. So I think it's a nice summary of these hemorrhagic fever and outbreak-related antiviral infections, including SARS, with useful information should you ever be confronted with an outbreak. Gastrointestinal pathogens, of course, are covered, and there is a comprehensive section on dosages and adverse effects of antivirals in this area. The table also includes recommendations for CMV, HSV, RSV, VZV, and the viral hepatitis syndromes, in addition to the respiratory and gastrointestinal pathogens. The antiviral section also has a richly detailed adverse effects section with the most important ADRs listed. And you can see that here, for example, for ganciclovir, where the drug is described including dosage and route, and then the adverse effects section notes some of the black box warnings that are published with this agent, which are significant because some of these agents have very high toxicities, and their use has to be considered in the context of what other comorbidities a patient may have. Now, the Sanford Guide section on HIV antiretroviral therapy, I think, is perhaps one of the most referenced in the guide, and has a strong emphasis on the treatment-naive patient. It's designed to be a quick point-of-care reference to the essentials of HIV therapeutics, especially with as I said, the treatment-naive patient. In particular, I feel the selected characteristics of antiretroviral section and the adverse effects sections are outstanding. But if you yearn for more information, the Sanford Guide to HIV/AIDS Therapy has been published every year since 1992. Now, in the interest of time, I cannot cover it here, but it is separately available. And I think if you treat a lot of HIV patients, it's really an essential guide to have available in your pocket. The first page of Table 14D is put together at the level of someone who is, I think, totally new to antiretroviral management. Basic concepts are presented, such as when to start therapy, how to treat acute HIV infection, and how to combine an appropriate antiretroviral regimen. The focus here on this page is on constructing a regimen for treatment-naive adults. Recommendations, of course, reflect the DHHS guidelines, which are oftentimes revised on a yearly or bi-yearly basis, and when this update occurs, of course, they are revised in this table. And I think that, in my opinion, most clinicians with very little of a background in HIV therapy could at least arrive upon an antiretroviral regimen, a reasonable one for any treatment-naive patient based on the recommendations in this table. Table 14D has a fairly comprehensive summary of each antiretroviral, including dose info, PK information, the route of elimination, and the major adverse effects. Table 14E goes in depth regarding ADRs, with the most common side effects bolded. Drugs are now organized by class. Now in ID medicine, we get many consult requests regarding antimicrobial prophylaxis. If you haven't committed this to memory, in many cases it's just a matter of looking it up. I think many of you out there will agree that infectious disease clinicians do get contacted a lot about this information, and in many cases it's just a matter of looking it up if you haven't committed it to memory, and offering those recommendations to the consulting physician. An example of this is in post-splenectomy bacteremia. Now, for many years when I read this section, amoxicillin clavulanate was recommended. In the current edition, when I checked again, I found that the authors are now recommending cefuroxime, or a respiratory fluoroquinolone, as additional options. This is the beauty of the Sanford guide for me. Nothing with this guide is stagnant. The tiny text within these small pages is constantly in flux, and you can keep up with the changes just by looking up things you thought you knew but really didn't. Surgical antibiotic prophylaxis is also covered, not just for cardiovascular surgery, but also for head and neck, colorectal, neurosurgical, and orthopedic procedures, to name a few. Table 15D is a nice comprehensive section on post-exposure prophylaxis. Even if you have never taken care of a PEP patient before, a post-exposure prophylaxis patient before, and study this section carefully, I think you should be able to handle one of these 2 a.m. phone calls. And for many of us who are new to infectious disease or in training, this guide and this table should be at the bedside when you're on call. HIV exposure management here in table 15D2 includes an algorithm on the type of post-exposure prophylaxis, the type of exposure, and what is recommended in terms of whether antiretroviral therapy should be offered or not, based on the risks of exposure and the degree of exposure. Once you determine the HIV status and the type of exposure, recommendations are then given for whether a basic, expanded, or alternative option should be considered. Table 15E involves prophylaxis for hematopoietic stem cell transplant or solid organ transplant. Again, this is also a knowledge base that perhaps is less well known to many clinicians who don't take care of solid organ transplant patients regularly. However, if you are an infrequent caretaker for these patients, prophylaxis for some of the most common opportunistic infections are listed within the table. And I think this is a particularly helpful section for those providers who practice this field of infectious disease commonly, and also, as I've said, occasionally for those who don't. Now, a common challenge for ID clinicians is the increasingly more complex process of dosing antibiotics for renal insufficiency. This is especially true in those who receive hemodialysis because of the move to different style dialysis filters in recent years that have different characteristics and clear antibiotics in different ways. Table 17A includes mathematical formulas for estimating creatinine clearance in both the non-obese and obese patient. There's also some information on what weight should be used to calculate dosages. The aminoglycoside section includes dosing information for both multiple daily dosing and once daily dosing of aminoglycosides. Information is presented regarding the different types of dialysis membranes. Another interesting thing on this page is a section that indicates that there is presently no data included on the renal dosing of doripenem. So we need to continue to remember what information resources are available for the use of certain agents, and keep this in mind when we're prescribing them. The last of the essential sections in the Sanford Guide is this page, which indicates which antimicrobials do not require dose adjustment with renal insufficiency, as well as those antimicrobials that do require dose adjustment with hepatic disease. So we've covered the pages of the Sanford Guide that we should all tab or dog-ear. Next, I'm going to discuss the sections that, in my opinion, you will also find extremely useful, though perhaps not on an everyday basis. Now, for community-acquired MRSA, here the authors have said, there isn't a lot of information in the literature, so this is how we think you should manage community-acquired MRSA infections. An important emphasis that they place in this section is what to do in the event of a first failure of a primary regimen. Combination therapy in serious infections is also addressed, I think, in a very useful way. Now, as an adult ID clinician, I've probably used this section perhaps 6 to 8 times in my career when I had a pediatric or young adult patient and needed to dose an antibiotic. I believe that the pediatric ID clinicians have more comprehensive sources for this information, such as the Red Book, but it is a good reference source for practitioners who occasionally need pediatric dosing information. Similarly, this table highlights childhood vaccinations in an easy-to-read format. Table 22A is a handy guide for drug-drug interactions listed alphabetically, with the most common cross-reacting compounds listed for each antimicrobial, as well as the significance of the interaction. Now, for me personally, I prefer to use some of the electronic references, such as Hippocrates, for looking up specific drug-drug interactions I'm interested in. But I think where this section excels is in telling you for a given antibiotic in a very quick way what the most common interactions are and which ones are the most significant. Now, how would I describe these last sections? They're kind of like the extra cream in your coffee, the fortune cookie in your Chinese meal, the relish on your hot dog. Definitely not essential, but still nice to have every now and then within the guide. Now, as ID specialists, drug desensitization is something that we would normally reserve for our colleagues in allergy and immunology. But the protocols are actually not that user-unfriendly and are listed here. I think this is probably designed for centers where allergy and immunology is not available, and perhaps ID and pharmacy would need to get involved. Now, if you want to look up PK data on antibacterials, complete information is listed here in Table 9A, although it's listed based upon a single standard dose per drug. Table 19 provides information for the dosing of antimicrobials in the treatment of CAPD peritonitis. If you have to dose these patients with PD catheter-related peritonitis, that information is listed here. Some other just in case you need it information. Wound classification and tetanus immunization schedules are listed in Table 20C, allowing you to categorize what type of wound you have in a given situation, as long as whether patients should receive tetanus prophylaxis. So this is a very helpful section. Again, not something that you would need every day, but when you do need it, it requires rapid attention, and it's nice to know this information is in your pocket. Now, the rabies post-exposure prophylaxis page gives a nice summary of which animals are at higher risk for rabies, and also advises on bite wound treatment based upon vaccination status. Correct vaccination sites are also mentioned. The last two sections are a table of information resources and a list of generic and common trade names. Again, not essential to have, but if you ever need to look up this information, it's nice to know it's in your coat pocket within your Sanford guide. Now to close, I'd like to tell you about what is likely to be the future of this 40-year-old publication. It's the Sanford Guide Online. Recently, the publishers of the Sanford Guide released this online version, available via subscription at www.sanfordguide.com. Now, the advantages of this version are several. First, it's available anywhere where someone would have access to the internet. No longer will you encounter a situation where you have to lament, "Darn, I left my Sanford Guide in my outer lab coat," and can't retrieve it. Second, like UpToDate and Micromedics, I can see many hospitals adding this as an online resource, which will greatly increase its availability to providers. Third, the Sanford Guide will now be available and be updatable, not yearly, but continuously, ensuring that the most up-to-date therapeutic information is available to the clinician. And lastly, the new format may allow the authors to do more with the information than they could do with the standard Sanford Guide, such as color coding of charts, using animation or more detailed diagrams, and linking reference information directly to citations. Here's a sample search for bacteremia, and the following listings appear. If you select Staph aureus bacteremia, as noted in third or fourth lane down, this information comes up. The information exists also in table format. Here's the section I spoke about earlier on drug-drug interactions in the online version. Again, very similar to what's seen in the pocket version. An obvious companion to the online version would be a version using more advanced data presentation and display technology for a modern smartphone. More and more medical reference sources have migrated out of our pockets and into our phones. The Sanford Guide publisher tells me that this is under development, and I certainly hope we can see it soon. I'd like to acknowledge the tremendous support from Jeb Sanford and Antimicrobial Therapy, Inc. for their assistance in putting this presentation together, particularly with a historical perspective and with reproductions of the tables. I'm very grateful to them for their support of this project, and I hope that I've given the audience a good representation of all the information that's available within the Sanford Guide that will keep it an essential reference in your pocket. And to those of you in the audience listening to this podcast, thank you very much for watching. Get out those Sanford Guides and take good care of your patients. Good day.